Okay, so the aim of this presentation is to describe a data linkage project that we are undertaking using multiple data sets to talk or to highlight the potential benefits of data linkage, but also to identify current barriers to efficient implementation of a data linkage project. Our research group has a significant interest in using evidence to drive treatment and treatment change. Over the past 15 years, we've built optimal treatment pathways based on evidence-based treatment guidelines. Evidence-based guidelines and evidence-based decision trees are able to provide information so as to calculate the appropriate proportion of patients of a particular tumour type that might receive a particular treatment. However, studies have shown that patients are not necessarily treated according to guidelines. This variation might be due to reasonable reasons, such as excess comorbidity, patient age, or patient choice. But there are also other reasons that may not be considered appropriate, where patients are missing out on therapy that would be considered appropriate based on the evidence. In order to bridge the gap between optimal care and actual care, it's imperative to understand the factors that predict the reasons why there is a gap between optimal and actual care by drilling down on some of the treatment data that are freely available. The map on the right-hand side shows a study that we have previously done using data from 2004 to 2006, which highlights individual patients who did or did not receive radiotherapy and had a diagnosis of cancer. The green dots indicate patients who have had a cancer diagnosis and received radiotherapy. The red dots are those that had cancer and did not receive radiotherapy. Ignore the red dots near the borders. That's probably because they were treated in the adjacent state, so those patients were excluded. Our study found significant underutilisation of evidence-based radiotherapy in New South Wales, and one of the factors that contributed to that was distance from a radiotherapy centre. Given the fact that country centres have now been built since this study was done, we want to repeat this study to see what effect the country centres have had on overall utilisation. The aims of our proposed study were to use data linkage to assess tumour data by stage, tumour type, and whether or not patients received radiotherapy in New South Wales in a more modern time period when some of the radiotherapy treatment centres have been built. What I'm showing now is the project timeline to date for getting permission for using the data such as clinical cancer registry, central cancer registry, admitted patient data, radiotherapy information systems, and births, deaths and marriages. Those that are completed in green are highlighting the aim of this presentation is to show that it's taken 12 months to do the paperwork. Progress to date has taken over a year to obtain the appropriate approvals by ethics committees, data custodians and data linkage authorities. This is because the data are held by multiple different agencies with different levels of understanding of our attempts to link the data and with different priorities with respect to signing off on data requests. This is not a unique experience to cancer or in New South Wales specifically. However, I think that we could do better. No results for this study are available at this time, but we continue working with these authorities to expedite the data linkage, and we are hopeful we will have linked data within the next month or so. So the purpose of this presentation was to highlight the fact that despite data linkage being a relatively efficient way of linking data and getting a complete data set, it remains slower than optimal. I'd also like to point out that this recent experience is actually faster than our past experience. So the study I showed you in that earlier slide took 3 years to get approval, as we had to go through 17 different health districts in order to do the data linkage, to the point that the PhD student nearly had to change his PhD topic to how to get 75 signatures in 3 years. Data linkage should be an efficient process while protecting the privacy of individuals. It's important that we streamline this process so that we're able to do analyses on modern data rather than old data where the conclusions may no longer be relevant. To maximise the benefit of data linkage, we would recommend that systems be developed to lower the level of bureaucracy involving linkage studies by having an agreed, approved, linked data pool of relevant de-identified data with centralised data custodianship and approval, or for the pooled data to be freely available to researchers, such as the model used over a long period of time by the US Cancer Surveillance Dataset, SEER. Thank you for your attention.